that's why it's mainly a adipocyte deposition. So that's why it's not a true hypertrophy, it is a pseudo hypertrophy. So when you have pseudo hypertrophy, it's more prominent at rest and less prominent on exertion. Okay. Second thing is the cardiomyopathy is more common in Duchenne's rather than Becker's. So you have someone who's Becker's having cardiomyopathy, it's less likely compared to, which is why I think you need to pursue the diagnosis further to clarify whether it's actually Becker's or something else. Any other questions? Okay, sure. Thank you. Next, we'll have Divya from Medicine 5 on hornet's nest. What did your this thing heading mean?
It's a Tamil word of muscular dystrophy.
Good morning. Today I'll be presenting on behalf of Medicine 5, the hornet's nest. History presenting Mrs. K, a 65-year-old lady who presented on 7th of this month, who had a slip and fall at her house where she fell over a hornet's nest, following which she sustained multiple hornet stings over her face, neck, upper limbs and lower limbs. Following this, she applied lime powder over the sides of the sting. Following this, she experienced a severe burning sensation all over her body associated with generalized swelling. However, there was no history of swelling of the lips or the tongue, no history of any breathing difficulty, giddiness, loss of consciousness, chest pain or palpitations. She was then taken to a local hospital where she was noted to have pulse rate of 86 beats per minute, BP of 140/90, and she was given symptomatic treatment with avil and dexamethasone. She felt symptomatically better and returned home. Around 3 hours later, she again had vomiting, for which she was taken to a local hospital and she was found to have desaturation and then referred to CMC for further management. She did not have any previous comorbidities. On examination, the patient was conscious and oriented. Vital signs, pulse rate was 118 beats per minute, regular, and she had a bounding pulse. Respiratory rate was 20 breaths per minute at presentation, and BP was 180/90 millimeter mercury at presentation, and she was afebrile. In the emergency, she was noted to have desaturation to 86% with increased work of breathing with respiratory rate of 28 breaths per minute, and was started on NIV and shifted to the ward. So the general examination showed redness over the sides of the sting, over the face, earlobes, upper limbs and legs, and generalized swelling. However, there was no angioedema. Respiratory system examination, she had bilateral normal vesicular blood sounds. There was no wheeze, and the remaining systemic examination was normal. On investigation, her HP was 212.3. Total counts were 11,000 with neutrophils of 67. Platelets were 4,12,000. At presentation in ED, her creatinine was 1 with a urea of 33. She had liver injury with total and direct bilirubin of 2.38 and 1.17. Her liver enzymes were elevated to 8,000 and 2,000 AST, ALT respectively, and her alkaline phosphatase was 147. She also was noted to have deranged coagulation parameters with an INR of 1.35 and an APTT of 55.6. She had elevated LDH as well as serial elevation in cardiac enzymes and elevated CPK levels also. Her ECG had shown normal sinus rhythm and a chest X-ray was also normal. Summary, she is a 65-year-old lady who has, with no comorbidities, sustained multiple hornet stings and has come with a multi-organ dysfunction with an AKI, ALI, rhabdomyolysis, myocarditis, and metabolic acidosis. In the ward, within 6 hours, her renal function and liver function was seen to drastically worsen, with her creatinine going up to 2.28 and liver enzymes multiplying up to 3 times from 8,000 to 24,000. ALT had elevated from 2,000 to 6,000, and her rhabdomyolysis had also significantly worsened within 6 hours. The ABG in emergency had shown metabolic acidosis in the ward. Even after receiving isotonic bicarb, her acidosis was shown to not improve. So I would like to speak on, normally when we have Hymenoptera stings like bee stings and hornet stings, we usually expect an anaphylactic reaction. However, in this patient, she had a much more exaggerated systemic response. The Hymenoptera order includes bees, wasps, hornets, and fire ants. They all inject venom via modified ovipositors. Vespidae, the hornets and the wasps, compared to bees who have barbed stings, they do not have barbed stingers. So one hornet can sting multiple times. So for this patient, she fell into a hornet sting. Even though there might have been only 10, she might have sustained multiple stings. And the venom is a mixture of multiple proteolytic enzymes, lipids, carbohydrates, phospholipids, phospholipases, as well as Allergens, specifically allergen 5 in hornets. They also have mastoperans, which cause mast cell degranulation, which cause systemic inflammation. So this is the flowchart showing the mechanism of action. Venom, once injected, will initially cause proteolytic enzymes to cause the degradation of the surrounding enzyme, which will release histamine from mast cells and basophil activation. For a single sting, this will result in anaphylaxis and local inflammatory response. This is an uncomplicated local reaction. However, if the stings are more in number, they can have an inflammatory response, which can cause worsening of the surrounding tissue, which according to textbooks have been defined more than 5 centimeters is defined as a complicated local reaction, then which will result in vasodilatation. However, when they have multiple stings, they can have venom-induced toxicity, which will result in multi-organ dysfunction, causing systemic reactions. And following this, if they resolve and improve, following 2 weeks, they may have delayed serum sickness also noted. So the lesser common effect, which are the severe systemic complications due to massive envenomation, are in the renal system, they can have acute renal failure. Nephrotic syndrome also has been documented in very rare cases, and associated renal tubular acidosis also has been documented when they have phospholipids causing tubular injury. Cardiac injury is myocarditis. They can have a myocardial infarction and arrhythmias. Hepatic injury is ventrilobular necrosis and pericholangitis. And neurologically, they can have strokes, GVS, and acute encephalopathy also has been seen in case reports. Hematologically, they can have hemolysis, DIC, and thrombocytopenia. And rarely, vasculitis also has been noticed. And previously sensitized patients have been noted to have more severe reactions. However, that is more documented in the anaphylactic changes. The systemic, it is also noted that the patients who had multiple these things never had anaphylactic changes. They never had angioedema or hypotension at presentation with the anaphylaxis, and they had only multi-organ dysfunction. So in arthropod textbook, they had documented that the lethal dose for multiple venom stings in a hornet sting would be around 1,500 stings for a 75 kg individual. So there have been case reports and case series alone on this topic. This is a South Indian case report in Kerala where a patient was sustained multiple wasp stings. He was noted to have renal failure, hemolysis, rhabdomyolysis, and liver dysfunction with elevated liver enzymes. He required intensive care with supportive management only. The supportive steroids and antihistamines were given only for the first 24 to 48 hours for covering the anaphylactic response. And he required hemodialysis. He remained anuric for 14 days, and he was given supportive hemodialysis till the urine output improved, and he improved symptomatically. This is a case series from Vietnam where they had classified patients with multiple hornet stings as patients presenting within 3 days and patients presenting after 3 days. They had also again subdivided as less than 50 stings and more than 50 stings arbitrarily. And it was noted that patients presenting less than 3 days with more number of stings in the group B had a higher renal failure, as well as deaths were also higher in the same group. The patients who presented after 3 days with the increased number of stings had lesser number of deaths. They have documented saying that this is probably because of the venom-induced systemic toxicity causing vasodilatation and all would have been more in the less than 3-day period. The time duration for the action of the venom-induced action was probably less than 3 days, and probably the patients who presented after 3 days may not have. This was a tertiary center, so they may not, all the patients may not have come to this tertiary center after 3 days, and they might have died elsewhere. So it was noted that 100% patients in the patients presenting after 3 days had renal failure. However, the deaths were higher in the patients presenting less than 3 days, and it was zero in the patients presenting after 3 days. So this was the mechanism of acute kidney injury in these things. Ischemic as well as toxin-related acute tubular necrosis. Ischemic was vasoactive substances causing vasodilatation and renal ischemia. The toxin-mediated was rhabdomyolysis, hemolysis, as well as the venom acting as a nephrotoxin. This was a case series showing toxic hepatitis in hornet stings. It was noted that the liver enzymes in the patients had significantly increased in the first 2 to 3 days, and it was shown to gradually reduce in the following days. And the coagulation parameters as well as the bilirubins were also shown to gradually decrease over time. So our patient, she was shifted to ICU in view of severe metabolic acidosis and hyperkalemia. She was started on hemodialysis, and she also required mechanical ventilation because of severe metabolic acidosis. Currently, she has been extubated. Her liver injury has been shown to improve. However, she is still persisting to be anuric and requiring multiple sessions. She still received 6 dialysis till now, still anuric. This is her liver function, which has shown to gradually improve, and bilirubins are increasing. However, the enzymes have almost normalized now. Renal injury is still has not improved completely now. So the take-home points are multiple these things may present with multi-organ dysfunction rather than anaphylaxis, and recovery of renal injury is much slower compared to other organs.
Other than the elevated cardiac enzymes, what evidence did you have of myocarditis in this?
She only had tachycardia in the ward during the hospital stay. Echo had shown normal LV function during the ICU stay.
Why do you think her CKMB was elevated?
CKMB would have been the muscle rhabdomyolysis, yes, also.
So it's more like the muscle. It's based on the elevated CKMB, you cannot label them myocarditis in someone who's got rhabdomyolysis. Second thing is your evidence you presented for shock, but your patient did not have shock. Right? Yeah, so it's more of the rhabdomyolysis causing the acute kidney injury rather than the shock and renal ischemia causing. So your evidence you presented for that, but actually your patient had more of a rhabdomyolysis than myoglobin. How much was the myoglobin?
Myoglobin we have not censored.
Next, we'll have Shrithi from Medicine 3. The next aspect.